which is great, right? So we're really going to discuss physiatry leadership in the post-acute care continuum, and a couple of things that we're going to really discuss is where are we with moving into the future. The very fact that you're listening to this webinar means that you are a prime candidate to take on leadership roles in PM&R as we move forward. And we're going to describe what those leadership roles are and what are the skill bases that will help propel you. To me, the number one predictor of someone being a leader in post-acute care in PM&R is that they have an interest in leadership in their early career. So, Joe, go ahead. Next slide. So we'll look at the scope of the challenge for physical medicine and rehabilitation in the post-acute environment. So I'll show you the breadth of that, and I'll review the opportunities. I'll review the challenges. Dr. DiTomaso will will discuss about how most effectively we can use PM&R leadership to move patients through the continuum of care. And then I'll go ahead and close it up with what I think are the most important leadership skills, what we do with USP to assist our providers in obtaining those skills, and what the Academy does on a national level right now to help promote education of our members, our AA PM&R members, in the skills and opportunities of leadership. Next. So just very briefly, I mean, I'm board certified in PM&R and pain. I've been working in pretty much all the post-acute sector during my experience, and pretty much every facet of post-acute I've worked in. And right now I'm primarily in IRF and also secondarily in skilled nursing facilities. I administrate. I'm the medical director of a 60-bed hospital in Harrisburg, PA, and I spent a lot of time working with the Academy, multiple committees at multiple levels. I initially launched my career with academics, primarily initially at Jefferson, and now I'm helping USP grow and provide a strong backbone provider network of PM&R physicians. The one thing that's not in here, and I just thought of, is that just to give you, everybody has to establish some degree of credibility when they talk about leadership, because it's really humbling to talk about leadership to future leaders, actually. And so I did serve time in the U.S. Air Force, and the pertinent part of that was I was in special operations, and actually I had 2 helicopter squadrons and 1 C-130 gun, is the way they were called, gunship squadrons. And basically I was in charge of the medical, putting together the medical ensemble for our mission, which was hostage rescue. So not a lot of people know that, but and that's where I was introduced to leadership by models, where it really mattered, actually. Next slide. So what's post-acute care? It's basically acute care hospital, LTACs, long-term acute care hospitals, acute rehabilitation, skilled nursing facilities, home health care, assisted living, the retirement communities that have a continuum of care, you know, from independent living to long-term skilled nursing care. And there's a new entity you may have heard of. It's called Hospital at Home. Very intriguing, where they actually provide nearly hospital level care from medical providers in the home setting. It's new, and I think that's going to be a strong entity in the future. And then, of course, there's outpatient care. That's the post-acute continuum that PM&R works in. So what are the challenges with all of those sectors? So we're going to primarily concentrate on acute rehab, skilled nursing facility, long-term care, and home health. And the problem with those sectors, they've risen to the top of everyone's visibility in the medical and CMS world and the Medicare world, because our costs in those domains have risen dramatically over the past decade and a half. They now represent 10% of all healthcare costs. They represent a variability in spending, a variability as much as 73%. So what that means is you can have a very different cost outcome within SNF per SNF per SNF, or IRF per IRF per IRF, and home health per home health. There's lots of variability in what the ultimate costs are, which CMS does not like variability in costs. And it's been disjointed and disorganized in how those entities transfer patients to each other. And of course, our goal is to get the best rehabilitation care for our patients at the lowest cost, right? That's the lofty goal. And that's the goal driven by payers. And as long as we get the best outcomes, we're okay with that as physicians, right? But to get from here to there is a huge, huge amount of effort. And then who will lead us? Next slide. So post-pandemic, some of the observations: the skilled nursing facilities have really, really taken a huge hit. And right now, many of them have fallen apart. And some of them have stayed together, but they're all functioning very differently than they ever had in their organization and their staffing. So right now, they've distinguished themselves against IRFs as we are the settings of choice for rehab after acute care, because the IRFs organization was really disintegrated, hopefully temporarily, but certainly now. And the other issue, before the pandemic, there were lots of pressure to increase the accountability, the fiscal accountability for post-acute care. And they were talking about prospective payment systems for nursing homes. Right now, they're paid on per diem. Site-neutral payments, where if you're a hip fracture and you go to an IRF versus a SNF, you get paid the same. That's Medicare's pilot projects. And then there was also the project to reduce aggregate payments. In other words, CMS would say, we want you to reduce our payments to you by 10%. We're going to reduce our payments to you by 10%. Deal with it. So all of those paths to cost control, which are a bit heavy-handed, have stalled because there's so much dysfunction in the system post-pandemic. You notice I'm being optimistic when I'm saying post-pandemic, but we believe this to be the case. The challenge is there will be so many patients flowing into the post-acute care arena in the next 3 decades. We're going to need every bed in every sector, in every patient slot in every sector over the next 30 years because of the baby boomer piling into the next 3 decades for healthcare needs. Next. So there was a study. It was really commissioned by the American Medical Rehab Providers Association, and it's 2014. So it's a bit old, but not too old. Dodson and Dobb. They had matched patient groups for a number of diagnoses: stroke, brain injury, hip fracture. And what they found when they compared SNF settings to IRF, it was SNF versus IRF, is that overall, SNFs initially, yes, they're less costly. And yes, the managed care programs like that because it costs them less and it makes them more when they don't have to pay out the premiums. There was also clearly a decrease in morbidity and mortality, significantly decreased in the IRFs versus the SNFs. The IRFs had lower admission rates. The IRFs had better outcomes. And the problem is, in the long term, how are we going to maintain cost? Because, CMS has a budget. It's part of our government, obviously. But it's clear that if there was a seamless way to integrate all the post-acute care facilities in any setting, it would likely reduce overall costs simply by increasing efficiency, reducing duplication of everything by having more seamless transitions. So it's basically the ability to get the patient at the right level at the right time. However the future decides, we decide that. That's ultimately the goal. Next. So, and of course, as PM&R, what we know very well is that we have strengths. We can do functional assessments. We have a good idea we have a very good idea, certainly the best idea of any medical specialty, of who's more appropriate for which level medically rehab wise. We have team skills where we can cross train a patient. We can run a team that consists of multiple post-acute care settings. We have knowledge of rehab services. We understand the medical issues and how they interface with PT and how they interface with OT and how they interface with speech. What are the needs now and in the future for those services for the patient's medical and rehabilitation diagnoses? We certainly are experts in managing chronic disability, and there is a lot of chronic disability, and there will be a lot more chronic disability as the population ages, which it is rapidly. We have expertise in pain management, which is a significant part of disability management. And we also understand the transition of care, how we as leaders could design, in the best of all worlds, how people could transition from a SNF from acute care, let's say, to a SNF, let's say to an IRF, to home health, to outpatient, to independent living, home program. We're the only specialty that's trained in that, and we could aggregately have a lot of experience in that. We're the experts, no question. Next. So how can we lead in those sectors? Well, we look at the top, they say 30,000 feet. Ideally, if people asked us to create pathways for stroke patients, as an example, in which they would go to the level they're best suited and then be transitioned to the levels that continue to suit them as they improve, we could do that. We could also assess the strength of post-acute care resources. What facilities would do a better job at that for a better outcome? With our team skills, we could certainly lead a care path medical team. Let's say we're in an integrated health system and you're the director of PM&R for that system, rehab for that system, and they say, we want you to lead our medical team, which consists of people from all of the post-acute sectors, and design a plan for patients as they come in. Just in the ideal world, if we were going to say, what's your dream? What is your dream of how we could envision how that would happen? And then we could certainly create protocols and criteria. I think we're very good at structured protocol and criteria development. Most importantly, our job as leaders is, since we have limited manpower, we have to educate ourselves on how, in a system of any size, we can influence the system to take good care of our patients, advocate for our patients in the most cost-effective manner with the best outcomes. We have to be able to influence that system and educate that system. And that way, we multiply our strength from the power of one physiatrist seeing one patient to the power of one physiatrist caring for and facilitating the care of many patients. Next. So there basically are, there's a number, as it exists now, there's a number of potential post-acute care models. And I'll just go through some of these, a few. Let's say a fully owned network. So I don't know if there is a fully owned network, and that means that one organization basically owns and manages the acute care hospital, the IRF, the SNF, the LTAC, and the home health organization, right? I believe there are some models like that, and I believe Banner in the Arizona area, that's what they're trying to do. So the good side to that is that you would think they own everything, therefore they could design a seamless system that would require, really good data management across all the domains of care, really good care integration as patients transition smoothly from one to another, and would require flexibility of the services in the integration of post-acute care, where people can't have one size fits all. The challenge is once you get a system that big, there are internal problems because of the size and because of their ability of everything that they need to do to integrate all those systems. So number one. Number two, the other potential model is aligned partners. So aligned partners is really how it works for me in Harrisburg here, mostly, where we're an independent freestanding hospital. So our efforts are to work close alignment with all of our acute care hospitals and to work with them to help innovate how patients get from there to here and where they go after us, and that we really help and support the other systems and partners to help them be efficient in whatever their goals are. The challenge is, everybody has disparate interests and financial drivers, right? Because acute operates differently financially than a SNF. But you have to work that out and just try to support your partner's success. And the other issue is data collection can be really difficult because we're not on the same EMR as our acute care hospitals, and so that's a difficulty we're going to need to circumvent at some time. So you need a constant realignment of that partnership of who is the providers of choice for who, and then make sure you're doing your job and that they're happy with it, with the end result being, reducing readmissions, the patients are happy with their care and their outcomes are good. But even in the aligned partners, that's clearly a lot of work. And then there's a hybrid system. And again, I'll give you an example in our area. Our two main acute care hospitals, they have home health care, but they are joint ventured with another organization that provides their IRF care and their LTAC care. So they basically have, they basically have, partial ownership and partial integration. That's a hybrid system. But the basic key overall is going to be an accurate data system across all those providers to assess the efficiency in common medical records so people can talk to each other and not have to duplicate medical records and find them, which has just been very challenging when systems are separate. Next. So I'm not going to go through these opportunities. Just know there's a lot of opportunities for leadership. My recommendation is whatever you do, if you're an acute care hospital, volunteer for an acute care hospital committee if you're looking into the consult basis. Or if you're an LTAC, approach the LTAC and say, I can be a consultant, I can be a program director for your brain injury program, your spinal cord program. In rehab, there's lots of levels. There's the medical director, you can be on the medical exec, you can be the associate medical director, you can direct a program, you can be a committee chair, or you can just be an attending. The same with the SNF, and the same with the home health care. You could be a medical director and team a team physiatrist for the home health care. And then the continuum, the continuum facilities where they have multiple levels of care, you can be a consultant or a program consultant. So there are so many opportunities. My recommendation is if you get on a committee, get on an opportunity that's going to help you work with other people and be a team outside the rehab hospital, you will get visibility, and then you can move forward from visibility. We'll discuss that a little bit in my next set. Next. So as far as the challenges for acute care visibility, PM&R is not always visible. A good example of when it is visible, if you're on the trauma team and you're the PM&R component, a lot of visibility there. So there are definite pathways. integration. So, you'll have to integrate with the physicians in the hospital. You'll need to be their colleagues. They'll need to know you. You need to know them. You need to make effort to do that. And then there's a priority. Rehab at this point is not high priority in acute hospital. They have other priorities that are much less costly or much more profitable for them. So those are some of the big struggles in acute. In rehab, our challenge in the IRFs is that we're so highly regulated by CMS. We have rules for this and we have rules for that, and we have the ALJ, and we have the local fiscal intermediaries, and we have managed Medicare. So highly regulated. You have to provide a lot of effort, and I know this from experience, to maintain connectivity with your acute care hospitals, because they're changing all the time. Their staffs change all the time. So you have to really be out there and be connected with them and their leadership as well. Specialty support, for instance, it's some hospitals struggle with some rehab staff struggle with getting specialists to see their patients. I mean, really important specialists like pulmonary and cardiac. And then there's the staffing issue, which is always a challenge, and certainly lately a big challenge. SNF, it's their level of organization. It can be poorly organized. It can be moderately organized. So few of them are well organized right now as we speak. They're rehab restricted. So rehab for skilled nursing facilities is a cost center. And that's been that way since 2019 with some Medicare changes. So for them, they make more money if they have to pay less therapists on the payroll. So challenge, all right? I'm not going to comment on it more than that. The post-acute reconstruction, we already talked about. Their deficits of staffing, which are enormous right now, and the funding. The skilled nursing facilities, they operate at very slim margins, and it's a challenge for them, and it's a challenge being a physician sometimes in that setting. And LTAC is the same thing as acute care. It's the visibility, the integration, and the priority that the LTAC gives PM&R. Next. So I'm going to let my great colleague, Dr. DiTomaso, take it from here.
All right, thank you. I am Craig DiTomaso, the Director of Early Career Physician Development for U.S. Physiatry. And, I think I couldn't say the kind of concepts better than Mike has already done. So let me try and illuminate them in a different way. Go ahead, Joe. So a little bit about me. I'm a board certified physician in both PM&R and TBI, and my area of interest for both clinical and research efforts is disorders of consciousness after severe traumatic brain injury. In private practice, I work in the inpatient rehab setting, LTAC setting, a little bit of skilled nursing and acute care consults. Administratively, I serve as the medical director of my inpatient rehab unit, and I have some previous experience as being the rehab director for a large academic rehab department overseeing all of the inpatient rehab sites. Academically, I'm currently an adjunct professor at UTMB, and formerly I was an assistant professor at Baylor College of Medicine. I also have this leadership role through U.S. Physiatry, and I am a speaker and consultant for Exobionics. But that's not the fun stuff. The fun stuff is thinking about how all of the skills and the time and the investment that you've done through medical school and residency and whatever work experience you had after that is going to pay off as you develop into a physician. So when you look at the training of physiatrists, when you look at what really happens in residency, usually things are broken down into their smallest elements. And that makes sense pedagogically, right? You're trying to make things learnable and digestible for new learners. But as you'll see later, that may be the opposite of what we need to do in the end. Furthermore, there's often a big focus in academic centers where we all learn from about specialization and being hyper-focused in a small area. And I think with good reason, because in those settings, it allows for a deeper understanding, allows for an expansion of knowledge, and allows you to really hone in and perfect your craft with a particular diagnosis or area of treatment. This benefits the academic centers in a lot of ways because they're trying to create individual centers of excellence so that this university can be known as the place to go for spinal cord injury or brain injury or back pain, whatever it might be. Having specialists in that area gives you some credence as being the true specialty center that's going to attract people, not just from the immediate location, but from the surrounding area as well. So in my academic background, I followed very much this pathway, right? My focus was on severe traumatic brain injury, and within that, people who had disorders of consciousness. As a resident, a fellow, and eventually an attending and a medical director within an academic setting, my career was focused on creating that center of excellence to further knowledge and specialty clinical care that would serve that subpopulation. The thing that became obvious to me over time, though, is as you begin to follow down that rabbit hole, you really have to get everything done for that patient, for that diagnosis, within that one center and within those confines. There isn't the freedom to move around because you are treating patients in a particular area. You are claiming that you're the best at that. So you've really got to bring those patients in and do everything there to kind of cement that role. And it changes your mindset and how you attack problems and how you deal with patients. So I teased this picture of these silos in my social media post because I wanted to bring it home. If you're a farmer and you're harvesting grain or wheat, rye, whatever it might be, you want to encapsulate those in particular silos so that when you go to sell them, you can tap into that and offer the customer exactly what they're looking for. In the same way, as academic centers have built these centers of excellence, they have kind of siloed PM&R into musculoskeletal care, pain care, spinal cord injury care, cancer care, and they've created experts around that area. While it has paid off in a big way in allowing those academic centers to market themselves, I would argue in some ways it's actually hurt the learners and the physiatrists in training who pass through those academic centers. Because when you're in the community, when you're in a non-academic center, it's really the continuity of care and being able to lead patients through the continuum that becomes most important. While it's true, you rarely have a center of excellence that's going to treat everything that deals with that particular diagnosis. You can most likely piece together most of what that patient needs, but it will require kind of dabbling in multiple different areas. So your expertise as a physiatrist comes to be with navigating that healthcare system, understanding what a SNF can do, what a rehab center can do, what an LTAC can do, and piecing it together in a way that makes sense for the patient. By maximizing the resources that are already there for the patient, you can usually achieve a pretty good outcome, maybe the best that's possible for them, without relying on one particular area doing everything for that patient, regardless of their diagnosis or their setting. So I have this cheesy picture drawing of Arnold Schwarzenegger here because I wanted you to think that power comes in a lot of different ways, right? And physiatrists certainly, I think, can make a claim to being powerful when you're running the #1 rehab center in the country, or you're known as the back pain epicenter of your area. But you can also be very powerful in other ways, right? Not everybody who's powerful has giant muscles like Schwarzenegger. Bruce Lee was very powerful, but was very slight of build, for example. In the same way, if you can tap a facility or even a couple of facilities, you can put together a continuity of care, a continuum of care, I should say, that really does more to help align the patient's needs and treats them for what they need to be done. And leadership within those different arenas allows you to help move that patient through there to achieve what they need to do at the right time when they need to achieve it. So leading in the post-acute care, oftentimes it's less helpful if you have very deep knowledge on one particular subject. For particular patients, that may be helpful, but for most of the patients, you're going to miss out on the things that they really need. While in the academic center or specialty centers, a lot of times you're focusing on creating new resources. You know, how do you create a bladder program for a spinal cord injury center that needs to add on bladder management, right? The focus would be more on trying to provide everything in one shop, which really isolates both you and the patient to one particular setting. Once you get out into more private practice, understanding how to leverage that again really becomes the power in the way that you help the patient, tapping into different areas as needed. So if you can optimize the care there, then you can really move patients through and optimize what the organizations do. This not only benefits the patient, which I hope I've convinced you, or at least mentioned multiple times, but it also helps the organization, right? Most organizations are simply not available to take care of every need of the patient, especially complex rehab patients. They're not doing a high enough volume to build large programs around that typically. But if you can tap into a skilled nursing facility that does very well at managing bladder, perhaps, or a rehab center that will restore mobility and meld them together, now you can create a continuum of care that will really serve your patients. Also, by moving the patients through the levels of care with a thought process, with some idea, you're going to maximize the outcome and minimize the cost, because the length of stay will be short, the transitions will be appropriate, and the outcome will be good, which will benefit everyone along the way, helping to give you more credence within the organizations themselves and furthering your ability to lead them. So I wanted you to take a look at this picture of this shamrock or clover and think back. I had the good fortune or bad luck, depending on your perspective, to attend Catholic school for a number of years. And one thing that we talked about a lot in Catholic school was that the Father, the Son, and the Holy Ghost, if you're familiar with Christianity and Catholicism, were 3 leaves of a clover with 1 stem. In the same way, when I'm approaching rehab patients now as a private practice physician, I no longer come to them as the disorder of consciousness, severe traumatic brain injury rehab specialist. I come to them as the physiatrist who's going to help them see the whole field. Because oftentimes, especially for patients who have severe traumatic brain injury, thinking that you're going to get everything done for them in one rehab stay with one payer is very, very unlikely. I'm not saying it never happens. Certainly it does. And certainly there are centers that have done very good at this. But there's a lot more brain injury than you're seeing at the centers that are listed by the U.S. News and World Report every year as being the top in the field. So for those patients, they've got to stitch together a continuity of care that will allow them to achieve their maximal recovery without access to a place that's going to create an entire program around their need. And so if you can use the best parts of the entire continuity, the post-acute care continuum, as Dr. Lupinacci outlined earlier, you can really, I think, do a lot for those patients. So to bring it home, to really give you an example of what I'm trying to say, I still see a lot of severe traumatic brain injury, but I see them in different roles, right? I do a little bit of acute care consultation. I am the medical director of a rehab facility, and I see them there. I also do consulting work at a local skilled nursing facility and at a local LTAC. And so I'm going to attempt to give you an idea of how that comes together to really give me some leadership credentials and some power within that field. So this is a gentleman. He signed all the HIPAA forms, so don't worry about that. But his name is Danny Fernandez, and he was the patient who I became very close with and worked very closely with his family. As you can imagine, Danny's trajectory after severe traumatic brain injury was not one that was linear. He had lots of ups and downs, as many of these patients do. So he spent some time in an acute care hospital. He had LTAC support. He did a rehab stay, and there was consideration of skilled nursing, although he didn't go there. But by kind of creating a continuity of care, allowing him to march from progression to depression place to place, and then eventually into the outpatient arena to get the services he needed there, we were able to give Danny a chance to recover. And as you can see, he went from the disorder of consciousness, intubated and non-responsive, to doing very well in rehab, and then finally in the bottom picture, coming back with his family to celebrate his success at my rehab hospital. So in this way, although I didn't have a particular high-functioning disorder of consciousness rehab program to plug him into, we were able to help shepherd him through different levels of care until he got the outcome that he wanted, and he was able to make a successful rehabilitation recovery. So what does it mean to me when we're talking about creating a way for physiatrists to lead in the post-acute? Well, I think it's lots of things. One, it's being active in an acute care hospital. There's lots of opportunities for leadership there. There's lots of people doing lots of great work in acute care hospital, but typically there is no one really leading the post-acute thought process. How do we get patients who need help recovering out of the hospital and into a place where they can really access those rehabilitation levels? Because no matter how many physical and occupational therapists, no matter what programs they have, that kind of rehabilitation is just not something most acute care hospitals can handle. And so you've got to look at how you bridge that gap to bring that to them. Next, in post-acute environments, you've got to know what different, oh, sorry, I didn't mean next slide, Joe. You've got to look at how different post-acute environments can best serve patients, right? So the rehab, the skilled nursing, the LTAC, whatever it is that you're connected with, they are probably not going to be able to do everything well, but there are probably things that they do very, very well. So if you can assess that and get the right patients there at the right time, you're going to optimize that environment. And you're going to be able to lead patients in and out of that facility, which will be very powerful for both the facility and the patients. And then lastly, you've got to understand how to change settings, right? As physiatrists, I think we oftentimes train in particular silos, and we don't see how important it is to help with that transition from one level to the next. Once you're in private practice, I think that's something that you can pick up, and I think it'll come natural to most physiatrists, but you do have to pay some time and attention to it to understand how to make those transitions and help patients transition there solidly. Once you can do that, then again, you can show some leadership, whether it's through formal committees or just through your patients and patient care in directing patients to other levels and helping them do so successfully. When you put that together, you really begin to find yourself leading the post-acute environment in your area, and I think you become a very powerful physiatrist indeed. All right, that's my last slide. I'll turn it back over to Michael.
I love Danny's story. Thank you for that. I think as clinicians, we always get a dopamine spike when a lecture brings us back to why we went into PM&R. And that did. So there's so many people like Danny that need our help, right? And in order to help systems be better at helping patients like Danny, there's certain leadership skill sets, and I'm not going to go over this in detail, but as in life, it's important to know what you know and know what you don't know. And there are certain basic skills that you will acquire and will need to hone as you move into leadership positions at any level in post-acute, as we've mentioned. So one clearly is negotiations, right? Because rehab and acute care and IRF and SNF environments and LTACs are very, very complicated organizations that have a lot going on individually with their management. So, when conflict happens, there's going to need to be people that can help lead a team to a decision. Some of that may be integrating everyone's problems into an integrated solution for a complex issue. There's always the issue with the systems that claim value but don't necessarily create or demonstrate value. And that's going to be a challenge in any of the post-acute sectors. And there are ways to manage through that. And then there are also well-known ways to craft package deals. So anyways, negotiation skills, really high on the ladder. Conflict management, right? So resolution skills, the ability to analyze behavior of groups and behaviors in organizations when those groups and organizations are in very competitive arenas, healthcare. There's a way at looking at win-lose and win-win as not necessarily one or the other. There are definitely intermediary things that happen between win-lose and win-win, and how does that move forward in the solution? How does that move forward in crafting an optimal solution? And then there are definitely things with trust, relationships, and reputations, and there cannot be enough said about those qualities within a leadership and a leader's capability. So really, the ability to brand yourself and sell yourself as a leader, you're not really selling yourself, right? You're just having other people notice the good work that you do. And how do they notice that? Well, there are basic concepts in reliability, cooperation, analytical thinking, and the ability to lead people and they trust you. So, the higher you rank in all of those areas, the more people will agree that your brand is good to move this entity forward, because those are the skills that it takes from the top. And also the ability to understand financial statements and accounting, and understand issues with financial assumptions and how those assumptions can impact results, and how to analyze a financial statement. Again, a knowledge base that was very helpful as you move on to in the realm of leadership and onto different leadership positions. And then the ability to master your organization. So our organizations are challenging, right? Any organization is challenging. Healthcare, I think, is more challenging because it's personal, right? It's personal to patients. It's personal to us. It's personal to Danny, very personal, right? It was personal to Dr. DiTomaso and that patient's care. So, but we have to realize in these complex environments, we have limited authority. And you have to have the ability to collaborate across boundaries, where you may not, where your authority is certainly not ultimate and may be limited. And how do you lead effectively without having formal authority? So there's a knowledge base that can help you. So within US Physiatry, we pride ourselves on helping our providers in their transition into our organization and in their work, whether they are medical directors, which we have a lot of, whether they are staff PM&R, whatever their issues are, whether they be medical, administrative, medical legal, billing and collections, in every domain, difficult, just difficult problems that happen in hospitals that involve physiatrists, because healthcare is just basically a challenging thing to do. And some people, when they first start, they don't have the experience. So we basically bring experience to our providers and help them in a very efficient way to manage through to the next level of success in whatever capacity that needs to be done. So also, fortunately, the Academy has an initiative. It's called Academy Bold, and it is about moving leadership forward within physiatry so that we can shape the future. In addition to do great patient care, we can shape patient care for many patients beyond our ability to do it one-to-one. Next. So, what we've discussed here is really well aligned with the Academy strategy, and obviously well outlined because we've been following the Academy strategy, and I have for a long time. But it's the Academy's belief that we have to have physiatrists involved at all levels of care, as Dr. DiTomaso clearly pointed out. So, and those domains on the slide are the domains that we can be involved in, and it's good to have involvement in as many as possible. Maybe you collectively, or you and your group, or you and your hospital colleagues, but that's the ideal. And the vision statement really was crafted so that the outside world understands that we're the essential medical experts in value-based evaluation and value-based diagnosis and in management of neuromusculoskeletal and disabling conditions, because we believe we are. Physiatrists are indispensable leaders in directing rehabilitation and recovery, and in prevention of injury and disease, and that we're vital in optimizing outcomes and functions early, for instance, acute care, or before that, and throughout the continuum of a patient's care in the post-acute care domain. So the physiatrists in the vision of the Academy, and I think it's the vision of all of us that have been practicing PM&R, is that we're the recognized leaders across the acute and post-acute continuum with expertise in managing utilization of resources to achieve maximum patient outcome. And you've heard that resonate through today's discussion multiple times. So the Academy actually has two paths that have developed. One is they've created a leadership institute, and within that leadership institute, there'll be skill development for two particular features. One is medical director certificate program. What are the essentials of becoming an outstanding medical director in rehab hospital systems, IRFs specifically? And also, beyond that, I mentioned that there are leadership positions in the acute hospital domain, and obviously in every other domain we talked about, but that require high-level business and administrative skills. So the Academy has joint ventured with Kellogg School of Business in Chicago, which is an outstanding business school, to create a program for leaders who anticipate they would like to lead at all levels in PM&R at all levels of programs in hospitals and hospital systems. Secondarily, this is a recent development. The American Board of Medical Specialties is in the process of finalizing work on a fellowship and board certification in medical leadership and operations at the hospital level. So again, this is specialized training for any specialist who wants to aspire to having leadership positions in integrated health systems or large acute care hospital systems. And that will be available for physiatrists who choose to pursue that path as well. So that concludes the more formal part of our presentation, and